2003 respectively. The National Award of Republic of Spain, Officers Cross Order of Isabella the Catholic in 2010, Mason Son Award from SCAI USA in 2010, and numerous other awards. It's an honor to host you, sir, today.
Thank you very much. Thank you.
Dr. Seth, India is facing a severe second wave of COVID-19. Is the Indian double mutant, as it is called, or the Indian variant, more contagious and viral this time?
That appears to be the case. You're absolutely right. The surge that we've seen, the second wave, as we call it, has been unprecedented and of the steepest rise seen anywhere in the world. And its multiplication factor seems to be very different to the last time. That is the reason why it surprised us. It took us totally unawares. It overwhelmed the healthcare system. And the reason is that there are three mutations. While it's called double mutant, it's got three mutations, one of which makes it very susceptible to rapid spread. It actually impregnates the cell far more rapidly, and it's at least 70% more infective than the previous strain. So clearly, and that is the reason why in practical terms, we're also seeing two aspects. One, that in the last wave, we used to see that when one person of the family was affected, say in a family of 5, perhaps 1 or 2 people would be affected, the others would escape, either better defense mechanism, less comorbidities, or whatever the reason. But at this stage, we certainly find that if one person gets affected very rapidly, the whole family gets affected. And therefore, it's clear that the multiplication factor is huge. Now, what is uncertain about it is, of course, the fact that whether is it just more vicious in terms of multiplication, its infectivity is greater, that's well understood. But I think that it's not yet clearly understood that it's whether it's more fatal. And I think that has to be, it can't be very clear unless we actually do a lot of larger and more clear epidemiological studies. Personally, it has a different mechanism of rapid worsening of patients, so that we used to see people worsening in the last wave around day 8, day 9, day 10, when their lungs would get infected. It's much more common to see people getting worse with lung affection earlier on in day 3 and 4, which wasn't the case earlier on. So it's fairly rapid in its spread. That is what I would say. And it's more vicious in terms of the seriousness of the cases.
So as you rightly said, doctor, that it is more vicious in terms of it's more rapid, and it's more vicious in terms of its impact. That is why we are seeing that in the second wave, more younger population, more youth population is getting affected by the second wave.
See, I think there are multiple factors in this, and I think we should put it into an all-round global perspective. We had older people getting infected last time, patients with greater comorbidities. Those were the first, the ones who got affected in the last wave. And we must remember that the last wave, we had a very early lockdown, and that there was gradual opening up, and gradually opening up not just of movement, but of life, of offices, of work, of transportation, and so on and so forth. So the youth did not get affected so much as the more elderly and vulnerable population, because more or less everyone was in some form of a protected atmosphere, which gradually opened up. But this time around, the virus has hit us when we had normalized, within inverted commas, which means that the younger gen was out at work. They were actually having to do mix with people. Many of these interactions are related to public dealings. It relates to traveling. It relates to using public transport. It relates to earning money and bread and butter for their families, and also looking after their parents. So which actually means that while this country consists of 50% of the youth, these were the people who got affected while the world was normalizing around every aspect, be it social, be it professional, be it work, be it movement, be it travel. And as you can understand, 18 to 50-year-olds or 80 to 60-year-olds are most active people in their lives. So first aspect was this. And second aspect, yes, the greater the virulence, the more the transmission, because it was in the terms of normalization of every aspect of life, and therefore the virus multiplied. And finally, we also must remember that the youth got infected also in a manner where certainly in India, many areas have more people per square kilometer than any other parts of the world.
The density of population in India.
Density of population is very large. So transfer, if virus gets virulent, its transference across multiple factors is very easily, and its multiplication factor increases exponentially related to the density of the population.
Sure. Dr. Seth, in the second wave, what we are seeing is that the crunch of oxygen, which in the first wave, it was not, whether it was not reported or not, that's a different issue. But right now, we are seeing and we are getting global aid as well. And why it is that in the second wave, the need for oxygen has doubled?
So you have absolutely asked a very relevant question. And let me just say the reasons for it. Firstly, that in the first wave, we were not overwhelmed in terms of our hospital beds to the same extent by serious patients. At that stage, when you heard that there were people roaming around or at least going from pillar to post looking for beds, many of those were patients who had mild illnesses as well. So at that stage, nearly 30% or 40% of our beds would be full of any COVID patient. If you recall, that was the norm at that time, that if you had COVID, you got admitted. And that's how we started functioning many of our COVID care centers. And that is why at that stage, the need for oxygen wasn't overwhelming. The second aspect which happened now is because of the rapidly increasing number of cases, in addition, therefore, we actually had more severe cases just in terms of proportion itself. While we still know that 90% or 85% would have mild illnesses and get better, just by absolute numbers, the number of serious cases were higher. And therefore, though hospitals are now full of more serious cases rather than mild cases, that was the first aspect which happened. All these were patients who were requiring oxygen because the mild cases and those who had minor requirements of oxygen stayed home because there were no beds. So it was all serious cases. And thirdly, because of the severity of their lung involvement, their oxygenation requirements were actually high. So suddenly we had patients who were requiring oxygen. In fact, all patients who got admitted required oxygen, and many of them required really high concentrations of oxygen. Finally, as you know, the treatment of COVID, lung disease, is actually oxygen. And these patients do require large amounts of oxygen. So suddenly, most centers started realizing in a very short span of time that the oxygen requirements increased double or 3 times compared to the normal. And therefore, that was the whole problem of it. So yes, it related to seriousness of illnesses and seriousness of the patients who were getting admitted in this wave compared to the last wave. And that is what I think we did not foresee because it happened too rapidly. And what we didn't take into account is that the variant strain would be so virulent that it would not give us time to act and think.
Sure. Because this time what we are seeing is that more lung involvement, as you rightly mentioned, Dr. Seth, is that earlier in the first wave, we could see more cases of flu, COVID causing flu. But in this wave, it is more causing pneumonia, in which case your oxygen requirement is high because your lungs get filled with fibrosis. So that might be the case, that this particular variant is causing pneumonia. Apart from social...
And I might just add that, most of these patients do require very high concentrations of oxygen. So it's not just a few liters, 2-3 liters of oxygen, but many of them on high flow masks, which actually take 15 liters to 50 liters of oxygen.
60, 70 also sometimes.
That's right. And that is the reason. And because it is inflammation, it's not a direct infection. It's an inflammatory reaction. It's microclots forming inside the lungs. All that leads to really need for high concentration of oxygen to even get their oxygen levels of the blood above to a respectable level for them to be able to survive or breathe.
Absolutely. Dr. Seth, now, apart from the fact that social distancing is the key, which was a key word since the beginning of the pandemic last year, do we now see vaccination as the only way to overcome the second or possibly a future third wave?
So we must understand that we need to break the transmission of the virus. And in simple terms, what it is that the virus multiplies within the throat. If I was to even tell you and start off this conversation by saying that it's arguably a non-living particle, that would surprise you to say, because it hasn't got a DNA, it's only got an RNA. So in terms of a cell, it should have a DNA and RNA. And that's why we can also argue that virus is a non-living particle because it's only an RNA. But on the other hand, can you see the virulence of this microscopic, submicroscopic, arguably a non-living particle, which has absolutely changed the world and the way we live in? It is just somehow, it's transformed a whole change in terms of behavior. Now, we must say that because it multiplies in the throat, the only way to stop it is transfer. That's the one way that's the only way to stop it. If it finds somebody who's got immunity towards it, it may go from me and find that it's not being able to multiply within me. And then it goes to someone else and can't multiply unless someone else, and then goes to a third one. In 3 or 4 transmission, the virus dies off over a period of 5 to 7 days because it can't multiply any further. That is the concept of vaccination on the herd immunity front. That if we were able to vaccinate a large amount of people, then the virus may not be able to survive. So it doesn't need 100% of the people to be vaccinated. But as long as 70% or 60% or 80%, that's somewhere the number, then the virus may not survive. And the virus would gradually just succumb into a very minor background virus. On the other hand, immediately, on an immediate term, the virus can be broken by masking, by absolutely what we call the COVID appropriate behavior, because that can stop the transfer of the virus right now as we sit and talk. If we have masks on, and I might emphasize, can I emphasize on your channel to understand, and we'll come to the vaccination part. So I would just say there are 2 ways to stop it. One is a COVID appropriate behavior, and the other is the vaccination. So let me first talk about the COVID appropriate behavior, which starts straight away, which starts protecting everyone straight on and starts happening as of now. For example, we talk about last year we used to say that the N95 masks, which were not available at that time, were only for the healthcare workers. But now we have a surplus of N95 masks and they come at a lower cost. So I would clearly say that those who can afford N95, if they're going out or have to go out or have to be in circumstances which means that they have to protect themselves and others, they should be able to wear N95 masks. But however, I would expect that only 1% of the population may afford it. Majority actually still wear cloth masks. But if you wear cloth masks at this time, please understand that it's the time for double masking and not single masking anymore. And what I mean by double masking is clearly that a cloth mask does protect us and others to the efficacy of 40 to 50%. Nothing more than that. N95 protects us with 95% efficacy against viruses and COVID. So how do we actually get to that level in simple terms? If this is what we call a 3-ply surgical mask, which is now available, by the way, at ₹1 and ₹1.50.
Yes.
And this is what you see people wearing a lot of the times.
Yes.
But the problem is that it is open on both ends, as you can see. And for a mask to protect you, you have to be able to blow out and breathe in. And the mask should be such that it should be sucked in when you breathe in, and it should be coming out or balloon out when you blow out. That means you are absolutely okay. This wasn't meant for actually protecting you. It was meant so that you don't infect the patient when you're actually operating on a patient and so on. Now, if these loops, by the way, are tied at the ends, like I have done here, and the loops have got tied, as you can see, then if I then put this mask on, it gives me a better seal, as you can see here. Now it's got me a better seal, and this can give me a 75% better seal because it doesn't go in. And if now I was to think of this as a cloth mask, and if I was now to put a cloth mask over this and seal it completely, then I have a 95 greater than 96% protection on myself transferring any virus to myself or me transferring virus to others. Now, what that is this can be washed daily. This can be thrown away daily. And then just at 45 rupees a month to 60 rupees a month, I have protected myself and others well. So this I would emphasize. Double masking should be the norm very clearly. The second, of course, you yourself said, is social distancing. And I want to emphasize a second point in that. I know I'm taking time, but it is the most important thing I do believe. You see, we always said, do gaz ki duri. And that do gaz in public circumstances decreases to 1 gaz, as you see everywhere. People are wearing the mask under their nose, which is 85% of the people wear it like an ornament around their neck rather than up their nose. And the do gaz ki duri becomes a gaz ki duri or 1 feet ki duri. And what is not well understood is that more realize that it is the do gaz ki duri came with a thought process that transmission is through droplets. And the droplets are small drops, which will not travel very far. And if you spit out or if you blow out, then these droplets which carry COVID would just settle to the ground in 3 or 4 feet and fall to the ground, and therefore won't reach 6 and 8 feet away. However, what has been realized is that more recently that there is a lot of it which is airborne transmission as well, and not just droplets, which means that it floats in the air. What it means is that in closed spaces, your 8 do gaz ki duri is not do gaz. You can still transfer or catch the virus even as far as 10 yards away, 30 yards away. In fact, there have been transmissions to 60 feet away in closed circumstances. And therefore, it brings the point that if you're going to be traveling in buses, if you're going to be traveling and be in an auditorium, if you're in a situation where the circulation is to an air conditioner, which feeds the air back again, in those closed circumstances, you may be at a greater risk. That's why it brings me to this mask. That's why it brings me to not crowding. It brings me to ventilation systems, that it should be all open. Cross ventilation should be there. Windows and doors should be open. You should not be in crowded circumstances. And more so, if you have to use public transport, it brings me again to the masking and distancing. That double mask is the only thing which can protect you, because this could be airborne itself. And finally, washing, hand hygiene is so important that it's not just I'm talking about use of sanitizers. Just wash your hands. Just wash your hands regularly. Just use soap and water and clean your hands regularly. And that could prevent you. Now, we may say that for a number of people, the distancing is sometimes in the socioeconomic data we have and the disparity of living we have in this country. For some people, that could become a joke. They're talking about a harsh joke and cruel joke for them, because they're talking about their livelihoods. They're talking about how to earn money. They're talking about circumstances where their daily wages and sitting around, and they live in a small room where 4 people are living. And for them, it's a joke. For them, even sanitation itself is a harsh, unfortunate reality. So, yes, but on the other hand, the sadness of the country is that those who can do all this, those who understand it, those who are intelligent enough, those who are educated enough, those who can easily be setting examples, unfortunately are the ones who are the biggest offenders. And that is the saddest point. And we've seen that happen. We've seen the visuals of it. We've seen everything that we as a country have become over a period of time. So one of the most undisciplined nations across the world. We don't stand very highly on discipline or self-discipline, I would say. And therefore, it needed all the impositions of regulations. And I wouldn't call it lockdown, but imposition of regulations to actually prevent us from unnecessary gathering, unnecessary crowding, unnecessary travel, and unnecessary enjoyment, should we say. And that's how this. So I think that point is right. And then I've deviated away from the vaccination. Yes, that's the second way to stop it. It takes its time. On a personal level, it gives us 70% protection. It decreases our chances of getting COVID by 70%. Once the second dose, 2 weeks after the second dose, should we say, has been given. We would say with the vaccines which are available in India, it's 70 to 80% decrease in our chances of getting infection. But what it does That's at a personal level, prevents us from getting serious infections clearly.
Hmm.
And certainly our chances of dying from COVID go down as much as 99%. That is huge, that it prevents our chances of getting serious infection by 95% and death by 99%. So we're very well protected with vaccination on a personal level. It decreases once we're vaccinated, even with one dose, it prevents our chances of transferring over infection at our homes by 50%, even with one dose. On a community level, it actually creates herd immunity over a period of time. And I would therefore bring you to the single statement, which is the mission and vision of even COVAX group, is that no one's protected till everyone's protected. No one is immunized till everyone
is immunized. So vaccination is the...
So you're right. If we follow the two-pronged path of clearly again and again emphasizing that you owe it to yourself and you owe it to others to mask yourself appropriately, to protect yourself, others and family, and secondly, vaccinate yourself, then you are actually doing what you needed to do, which is, that is the attack on the virus. That is what will drive the virus to the ground. That is what will put the virus in the background. And that is what will bring the normality of life back over a period of time.
Naturally. So ramping up vaccination is the most important step. And how do we do it? I mean, what measures do you see must be taken to ramp up the vaccination?
Oh, this is the current topic of interest, discussion, and debates, as you know. We must say that in a 1.2 billion country, we just can't compare ourselves to saying that, we vaccinated X amount, because it's always going to be as a percentage of the country, we must remember. That is how the herd immunity comes in. We may say that we've actually got 5% vaccinated, but that 5% will not be relevant till it's up to 70%. We may be benefiting those 5%. So fine. We started very well, and we started with the right philosophy for a country which is considered to be the biggest manufacturer of vaccines in the world. We started by the right methodology, which we'd seen last year. A lot of elderlies and comorbid people had died. And certainly that's the group, the frontline workers, the healthcare workers who are directly exposed should be the first ones to get vaccinated. Because as you can understand, the healthcare workers and frontline workers are extremely valuable in this fight against COVID.
Yes, and they're constantly exposed. And
one of them suffers or two of them suffers. That means a loss of perhaps 10 times more lives because they're not available.
Yes.
So that was correct. And then looking at the elderlies and the more who are. But what has happened is that what should have been the powerhouse of vaccination somehow seems to have fallen apart. There was a talk when we started that we have 60 million doses available to us, which is 6 crore doses. We have the ability to manufacture 100 million doses a month, which is 10 crore doses. And we have a powerhouse which always stated that we have an ability to manufacture 2.4 billion doses a year. But I think that we fell apart somewhere in terms of understanding what it needs to ramp up. And I just don't understand why we fell apart in understanding this, because we are a country which has the ability to make people vote. 1.2 billion people vote. 70% of those turn out in an election process which just takes a few days for a national election. Worldwide, that would be considered impossible. And yet we are able to do that. And by the way, I fail to understand that actually when you go out to a voting booth, it takes you longer to vote than it takes you to get a vaccination.
Yes.
I hope you understand. You still have to show your card. You still have to get there. You still have to punch in, and you take that 5-10 minutes. It takes you shorter time to get yourself vaccinated. And by the way, every nurse can give a vaccination. Every technician can give a vaccination. You don't need doctors for vaccination. And by the way, even after 17 crore people have been vaccinated, you don't need that 30-minute wait for everybody to see whether a reaction has happened or not. After all, flu vaccine is given to us every year. There's so many vaccines to give every year. We just go to a doctor's clinic. We go to a GP's clinic, have a vaccine. He gives us a shot and we go home. As children, from children to now, we probably had 13 different types of vaccines. And so I think that we actually, firstly, one aspect is ramp up. And I know, and the government knows, and the government has its ability to be able to ramp up. So I think the government is going to look at that. Yes, our government has been efficient, I would say. And therefore, what's happening in this month, I would just discount it. Because this is going to be I have a lot of trust on our government because it has worked efficiently for us, thought through every aspect over the whole of last year. Now, they're going to be 80% of the things can be got right. 20%, the virus is going to overtake us and absolutely make us totally confused. And by the way, nobody is an expert, and no country's been an expert at it. No amount of experts can actually be forecast what this virus is going to do, because this is the first time such a virus has ever been seen across the world, and no amount of experiences can actually be, nobody can qualify that there are more experts at this than anybody else. Having understood that, if a government can get 80% of their acts right and forecasters, I think it's done a tremendous job, and it's got a great think tank in it. So what's going to happen is, and the government has the ability to be able to ramp up the vaccine production. There are many ways to do it. They've already put in money with the various companies who can ramp up their manufacturing.
Global tenders have been floated by states.
That's right. There's also the issues of ability to get vaccines from outside. There's also the issues of patents, and therefore getting those in a disaster time, getting more companies to manufacture the same vaccine, and that's also possible. So I think there are a number of ways possible, but I foresee that we're going to overcome this in a month's time. So this is very temporary. But when we overcome it in a month or two, we will be actually having those 100 million or 150 to 200 million doses that we want every month. And I believe that in a month or two, we will achieve that. This is not, we can argue about this 15 days, we can argue about the 3, but I think our agenda is, where do we stand 3 months from now? Where do we stand 6 months from now? Isn't it? It's not today and tomorrow's agenda. Are we not doing well today? Are we going to do well tomorrow? But as a nation, I know that everybody is focused at it. Our policymakers are clearly focused at it. I see ourselves sitting very pretty in 2 months' time. I see our ramping up exponentially in 3 months' time. I believe that we're going to meet our targets in 6 months' time of whatever we want to achieve. And we're going to have we'll have enough vaccines in our country to be able to get to that, not just, the 3 million, which we were at, but we're talking about 10 million doses a year. Yes, that should be 10 million. Yes, 10, because we've been vaccinating at 3 million a day. So I'm talking about, 6 million a day, and I'm talking about 10 million a day is what we need to achieve if we wanted to do something for our population. And I think that's achievable in our country with our policies. I think we just got a 15-day lag, because at the end, 18 to 48 needed to be vaccinated. People had to be given a second dose. And by the way, there could be other ways to look at this also. Perhaps we should be looking at, why not just vaccinate, give people, delay the second dose to 3 months instead of 2 months. That's something which has been done in Britain. That's something which is known by the WHO, has also recommended that it can be extended. The trials do show a better immunity if it's extended up to 3 months, or as we say, 12 weeks. And that may be one of the ways to actually extend at least the availability of vaccine to a larger proportion of people, at least for Covishield vaccine. So there are philosophies and policies around which will be looked at. So I'm not concerned about what's happening today with vaccination. We've done well.
About 15 days to 1 month's time, we will have the stock, and India can achieve the mark of vaccinating 10 million a day as well.
10 million a day.
Which will help about 300 million a month. And by that speed, it's just 3 months that the entire India.
It ends up at around 20. Yeah, it ends around not to 300, but it'll end up at 200 million a month. And if it's 200 million a month, we should be achieving.
In 4 months, we'll be your 80% of India's population is vaccinated.
And you know how it will be. So once the availability is there, it should actually be exactly like you and I have had vaccinations through our life. We go to our local GP and just say, I need a vaccination, and he gives you a jab, and you take your child back home, or you yourself go back home.
Actually, how the BCG vaccines and the polio vaccines are.
Absolutely. So we can do that. And so I see no problem. It doesn't need to have these mega centers with people queuing up and coordinating. It doesn't need to, thousands of people have to descend on one center to have it. If we can have elections with a booth every half a kilometer around us,
why not vaccination?
Why not vaccination?
Absolutely. Now, Dr. Seth, if we talk about the cardiology aspect of the COVID-19, and I speak of personal experience also, as I was infected last year with COVID-19, many people are, observing, and which I have noticed also, that after recovery, whether it's a mild case or a moderate case, their lipid profile is going up and down. I mean, people who never had any kind of cholesterol or triglycerides are witnessing a certain spurt, not a very, very high level of cholesterol or triglyceride, but a little spurt. Why is that so? I mean, is it thickening the blood, or I mean, what is the case behind it?
So I think we do two different aspects. The thickening of the blood we talk about in COVID versus cholesterol levels are two different aspects, and let's address both of them. And I think in this aspect, would you also like me to address how COVID affects the heart?
Absolutely.
I think it's an important aspect.
It's an important aspect, yes.
You see, last June, I wrote up an article in Hindustan Times which said COVID is not just a lung disease, it's also a heart disease, because we started seeing heart problems related to COVID across the world, including ourselves in our country, in the very early phases of COVID. COVID affects the heart in 25 to 30% of the patients who get COVID. Certainly 40-50% of the patients who die from COVID die because of cardiac involvement rather than lung involvement. And mild degrees of affection of the heart, very mild, which doesn't transfer into any clinical, may not transfer into clinical consequences, affects nearly 75% of the COVID patients. So that's a huge number.
That's a huge number.
And the way it affects is primarily because of the inflammatory reactions. So what happens is that two things happen when COVID causes inflammation. One, the blood gets thickened, so has an increased tendency to clot. And the second, that the arteries get inflamed, the arteries which supply the brain or the heart or the lungs get inflamed. That combination of arteries being inflamed and blood getting thick causes clots to form in the artery. And if the arteries of the heart have clots in them, blocking them, that causes major heart attacks, especially in the young. If it affects the blood supply to the lungs, that causes a condition called pulmonary embolism, where sudden chest pain and drop in oxygen occurs and a patient cannot even have oxygen going into the lungs. And finally, if it happens to the brain arteries, it causes that catastrophic strokes and paralysis. The second way it affects the heart is that direct heart muscle the heart is a muscular pump. And then if inflammation of the heart muscle occurs, the heart cannot pump stronger and becomes weak and gradually, rapidly goes down in terms of efficiency. And suddenly it can't pump blood and a shock situation occurs. A heart failure occurs. And finally, the conduction system of the heart may get affected by inflammation, causes the heart rate to go suddenly from 80, which is normal, to perhaps 180, 200, or from 80, it may suddenly go down to 20 and 30 per minute, which means patient goes into a cardiac arrest. These are the three direct consequences of the inflammation on the heart itself. Now, the problem is that the more severe the COVID, the more its affection on the heart. That is also well recognized. But unfortunately, even those who have milder forms of COVID and have recovered from COVID and are going home, suddenly they would actually, if investigated, may start feeling breathless and can actually have an affection of the heart, both in terms of heart attack or in terms of weakening of the heart muscle, even after discharge from the hospital in the subsequent course of the next 3 to 4 weeks. And that is why we say that a patient who gets discharged from the hospital after COVID should firstly never exercise vigorously, and which would, because it's possible that his heart has been affected and inflamed, and he would not know it. And when he exercises vigorously and rigorously, he would damage his heart further. Secondly, we say that do not ignore symptoms of chest pain, palpitations, anything which is related to the heart. See a doctor so that simple tests like an ECG and an echocardiogram can be done to diagnose any affection of the heart. And finally, let yourself recover over a period of 6 weeks to 2 months before you get back to your full physical activity. So we do an echo and an ECG after discharge and at 3 months. The thickening of the blood, therefore, is also prevented while in hospital by blood thinning injections, which are sometimes carried on to after discharge based on certain parameters, or at least in the ones who've had mild affection or not so serious COVID, aspirin as a blood thinner is also continued for a period of 2 to 3 months. So that's the safety. Now, that is the blood thinning and the thickening aspect of it. The second aspect is cholesterol. The cholesterol more relates not necessarily to COVID itself, but it relates to the fact that you're given steroids. While in hospital, you may be given drugs which actually make you gain weight. You then are not exercising. You're asked to eat well, and therefore, and sometimes the cholesterol medicine, people are on cholesterol medicine, which is actually removed at the time of the viral infection because it may interact with many of the drugs which are given, cause more weakness, cause more exhaustion, and they're removed. And that is why the fluctuations of cholesterol happen, because your whole lifestyle as well as drug therapy has been changed in favor of drugs also, which cause increase in cholesterol. That gradually normalizes, and we're less worried about that because that tends to normalize over a period of 2 to 3 months anyway. And then when you fall into your original routine and the original and exercise and diet routine, it all resolves. So we're more worried about the clotting part. We're certainly worried about its effect on the heart muscle, inflammatory reaction, blood thickening, less about the cholesterol.
Absolutely. So, I mean, regularly checking of pulse rate could be the first thing that a person who has recovered from COVID should do.
Yes, I think, and a lot of people.
Otherwise, how will he come to know? I mean, that whether it's not possible for everyone to conduct a blood test every 3 months, or
No, it is not.
How will one come to know?
So you come to know by understanding your symptoms. That firstly, if you're not feeling well. Secondly, you're right. If your heart rate remains high all the time, that's another reason to get a cardiologist to check you up.
Which is above 100.
Yeah, which is above 100. If you're feeling breathless still on walking around, that's another reason. So you start walking because, as you know, in hospital or during recovery, you're at rest. And when you start regaining your walks and you start exercising, or walking is the best exercise. And even at moderate level, if you feel breathless, that's another reason. And I would say that all individuals, young or old, after recovery from COVID, should at least have one cardiac check, which is correct, with an ECG and an echo to make sure that they are actually recovering fine without any affection on the heart muscle.
So one ECG probably a month or two after COVID recovery.
That's right. A month, 2 to 4 weeks after COVID recovery is a very good idea. And I certainly recommend it to most of my COVID patients.
Absolutely. And an ECG would give a proper barometer that your heart is functioning well.
ECG and an echocardiogram, both are very simple tests and both are easily doable and easily available as well.
Sure. Now, doctor, if we talk about antibodies, the importance of antibodies, how important is a person's antibody level, in various waves that come? So we have seen that a lot of people, and this also is from personal experience, that after the first wave, people who have recovered from the first wave, people have done tests within 3 months of recovery, 6 months. I have done actually after 8 to 9 months of recovery, and I've shown considerable levels of antibodies. So much so that their personal doctors have recommended them not to take the vaccine currently. If there is a shortage, you can wait for a while. So what is the importance of a body developing its own antibody through recovery?
So there are two aspects to your question, and I think I'll address those two separately. One is, after recovery, when can you take vaccine? That was, one of your thoughts when you actually got COVID and you said, when should I take the vaccine? The second is, what does those antibody responses mean? So after recovery from COVID, you are allowed to, or you should take vaccine, or you can take vaccine approximately 4 weeks after that, after recovery from COVID, which means that it takes you approximately 2 weeks to recover from COVID. And that's when we say that you're practically clear of the COVID. No more is earlier. Last year, we used to have 2 negative tests before we actually certified, 2 negative tests 24 hours apart before we certified anybody had recovered. That is not followed now with greater understanding practically across the world, where we say that if it's 10 days, which is from COVID, you're allowed to go home, or you're allowed to come out of isolation as long as it is 3 days after the last bout of fever. And by 14 days, you're allowed to circulate in the public without even having a test. It used to be around 17 days to be saying safe, 1 week after the 10-day discharge or from the hospital or from isolation. Now, therefore, what it means is from that time, approximately 4 weeks after that, you can take a vaccination. In the present circumstances, I would also state to those who've had COVID that they can relinquish their chance to someone else, because up to 3 months, we are more or less certain that that immunity would remain. Okay. Now, do the antibody levels correlate with that? No. I think is a very clear answer. You've asked $1 million question that whether after vaccination or whether after having had a COVID, is there any relevance of checking antibodies and seeing whether I'm protected or not? It's $1 million question which still has not been understood. What I'm saying is that there's still not been a correlation with the antibody level, which is anti-spike antibodies tested in the community or tested in most laboratories versus your own immunity, because your own immunity doesn't rest on antibodies alone. It relates also to B lymphocytes and T lymphocytes, which are lymphocytes which actually will respond only at the time when you get infected second time by a virus, and therefore will produce antibodies at that time. So your blood levels of antibodies may be low, but your T cells will start producing antibodies so instantaneously because they have a memory inbuilt when you get attacked. So the levels and whatever their levels may be do not necessarily correlate with your ability to fight fresh infections or for you to be immune. And that is what has been not understood. Unless one actually goes into another way to look at antibodies, which is to take the serum, go into a Petri dish, neutralize organs, and these are called neutralizing tests. And only neutralizing tests would tell us whether you can or cannot have further infections. And that's not done routinely because those are very complicated and limited testing, which is done in genome laboratories and so on and so forth. So let us just accept the fact that there's no point testing antibodies for your own protection, apart from as a part of epidemiological assessment and surveys, where we know that a person has antibodies, so must have had the infection. That is its only relevance. Okay. Now, so that is very clear. Level of antibodies will not decide for you whether you should have a vaccination or not after COVID. And sensibly, you can get it up to 3 months later. At 3 months, you should certainly have a vaccination for two advantages. Firstly, the vaccination, even one dose, would act as a booster for yourself because it will act as a second dose rather than a first dose, the first dose being your infection itself. And secondly, responses are more predictable in terms of immunity because it's a specific dose which is given, and a specific antibody response amongst large population has already been seen, as opposed to a mild infection, as opposed to a moderate infection, and so on and so forth. So coming to that immunization program also, this is very relevant. I talked to you about maybe we should actually be saying one dose to most people to cover a wider area so that the second dose can be delayed for 3 months. Even in that policy can also come in that those who've actually had COVID, and now, as you know, a reasonable proportion of people are having COVID, that they should also perhaps go up to 3 months for their second injection, so that again, it allows for them to stand back while others who haven't yet had COVID can take the first doses. So those are important points of expanding the reach when limited of supply of vaccines is available till more supplies come in.
Sure. Because Doctor, a lot of things and a lot of misconceptions are also doing the rounds. That, someone tests the antibodies who have recovered and they see that my level is 25. My doctor has said that, if antibody level is about 25, you can delay by a month taking the vaccine. Or I have 100 antibody, I have 150 antibody. Is there any cutoff level or no? These are all myths.
I did go into it myself also because I tested myself. And I tested my wife as well, who earlier had COVID. That's another relative. Now, I must tell you this. This is so interesting that, yes, A relative of mine had an antibody of 150, and I had somewhere around 30. And I said to him, that's where I went into it much more deeply to understand what was I doing. Why was I getting so worried about it? Then I realized that there was absolutely no relevance. And that got proven later when my distant relative who had that 150 had a second COVID infection after 8 months. And then I said, but of course, where was the protection at that level? So of course, that was a mild infection. But again, that was not relevant. It also becomes just less relevant because the COVID itself may mutate itself. And then of course, it also could bypass the immune system as time goes on. And again, that's the reason for a repeat infection of COVID few months down the road. Two things could happen. Firstly, of course, that the antibody levels could fall down or immune response could fall down. Or secondly, the mutant can actually bypass the immune response after a few months. And that can also happen. Or your immune response may not be so active against that mutant, maybe partially active against that mutant. That's the second aspect of everything. So I think overall, what one would say is no point checking antibodies. Keep up your immunization schedules. Keep up your immunity, should we say. And keep up the protection. The biggest vaccine, as you know, is mask, social distancing, not going out unnecessarily, not creating unnecessary gatherings, keeping sanitation. The COVID appropriate behavior is the social vaccine. And then we have the medical vaccine. And if we combine the social and medical vaccine together, neither the antibodies matter or the mutant matters, because these would protect you in all aspects.
So immunization has to be considered even for those who have considerable antibodies. Yes, instead of fighting for a slot early, they could just take it 10-15 days later on. Probably that's the only use, but everyone should take it. Now, last couple of questions, Doctor. People are now worried, and we've seen the media about something called as mucormycosis or black fungus. Are we looking at another pandemic, or it is rare and it is just confined to few with certain ailments or comorbidities, or are we looking at something really dangerous?
Kailash, it's rare. Yes, it is serious. It is life-threatening. It is, in fact, a very serious condition, but it is a rare condition. It actually affects. Even in the past, we've known mucormycosis as a very serious condition for those who've had cancer, for those who are immunosuppressed. Yes, it's a rare complication. It's a fungus which exists in the air. But if you're immunosuppressed, or if I'm immunosuppressed, it'll just get into my nostrils. It's airborne, therefore gets into the nose, gets into the sinuses, can go up into the brain through the sinuses, and just proliferates because the immune reaction is low. And unfortunately, patients with serious COVID are given large doses of steroids, are given drugs which are immunosuppressants in many ways, which decrease their immunity. Many of them are diabetics. The drugs like steroids put up their diabetes and make it out of control, all of which are niduses for this fungus to grow. And therefore, these reports of mucormycosis in hundreds of cases, but it's not thousands and it's not millions of cases as opposed to the number of people who are getting COVID. So it's important because it's so serious. It is important for those who have COVID and serious COVID, who've been in the hospital and been on steroids and injections and are diabetics, to watch out for the signs and symptoms of continuing fever, stuffiness of nose, aches and pains around the eyes, around the mouth, in the sinuses, high fever, blurring of vision, any strokes, etc. Those are important symptoms to watch out for and immediately approach the doctor for a checkup and make sure that it's nothing to do with any early mucormycosis or even sometimes delayed mucormycosis, which is serious. People lose their eyesight. People actually, it affects the brain. They go into an unrecoverable strokes. So, and sometimes they just have to have major operations to save the life and the fungus spreading throughout the body. So yes, that's why it's being emphasized, because of its viciousness and seriousness, but it's rare.
It's rare.
Yes.
Now, towards my last question, Dr. Seth, as you mentioned about people who are administered heavy steroids, injections such as remdesivir, and there's a whole lot of news on remdesivir, people holding at the need for remdesivir, an injection called Toxi. I'm not able to pronounce it well. Apologies for that. But the immunosuppressant.
Tocilizumab.
Yeah, Toxi.
Yes, you're right. Tocilizumab. You can just call it Tossi.
Tossi, yes. There's Tossi, there is remdesivir, there is steroids. And so when they should be administered, I mean, shouldn't that be the case that, anyone who is hospitalized should need that, or only in severe, like a person who's administering 94, 95 oxygen, does he need to be given something like a remdesivir or a Toxi or a steroid?
Not really. See, we must remember that this is a flu. The virus is a flu virus. It's just a different form of a flu virus, and that's why it causes the flu-like illness. And that is why 90% or 85 to 90% would recover if their immunity is strong, that they would recover without any specific medications, by the way. The West, where a lot of third payers and governments are treating their patients, by the way, they're not given anything apart from saying, stay at home, eat healthy, sleep well, drink plenty of water, be positive, meditate, and stay happy, and you'll get better. But here in India, of course, we have all those, we do give vitamins, we do give other aspects. Yes, ivermectin still remains a part of our treatment schedule. Doxycycline does remain a part of our treatment schedule.
At one point in time, it was hydroxychloroquine. I remember it was
and you're so right. And then the hydroxychloroquine waned away and ivermectin came in, and there have been reports of variable benefits or no benefits, but the West doesn't believe in it. In general, their strategy around mild cases is what I said, symptomatic treatment and keep your immune system positive. Now, and ivermectin's again research based on many reports, but let's leave maybe benefits, may not be, possibly beneficial stuff out. What is important is that the oxygen level is the first one, and these are mild cases, and that's when virus is replicating, and that's when inflammatory reaction starts setting in, and the inflammatory reaction starts going to the lungs. That's when oxygen starts getting affected, and that's usually 5 to 7 days into the illness. That is the reason why we say monitor your oxygen saturations, and monitor your oxygen saturations by pulse oximeter, which is easily available, but not just at rest, but after 6 minutes walk at least 3 times a day, before and after, in the young, and after 3 minutes walk in the elderly who are beyond 75 years of age, to see whether there's a drop in oxygen from a baseline of greater than 3 to 4%. If that is there, see, normally when we exercise, it either doesn't drop, and sometimes as we breathe in heavily, it can actually increase. So our level can go from 97 to 98. But if it starts going to 94, 93, that's the first sign. When it comes to a decrease in oxygen saturations, either on exercise or at rest to less than 94 and 93, we start believing that lungs are getting affected. Now, earlier, we would always say these patients used to have to get admitted. At this stage, where the beds have been absolutely very difficult to find because of more serious patients needing those beds, we're able to now treat the patients between 90 and 94% saturations at home. But it has to be in connect with a doctor. A patient can't treat himself and say, but I've got a 93% and 92%, but I've been told that that's okay. I can actually be staying at home. No. The patient should always be in touch with a doctor, even during a mild illness. That's when his first connect with the doctor starts, because it's the doctor to decide when that patient should actually be coming to the hospital, or if he's going to be staying at home, even with a lower oxygen saturation, then what is the treatment that he should give him at home, which can and monitor at home. So steroids is something which is to be given when oxygen starts dropping, when the inflammatory reaction starts in the lungs, usually in hospital settings, clearly, and never to be prescribed. Because if it's prescribed too early by a patient himself, and especially if it's within the first few days or first 5 days when the virus is replicating, there can be harm done rather than good by giving steroids. Now, it is possible that the doctor may say that start steroids at home. You're not so bad, but this is the time to start steroids at home. But that's under the supervision and advice of a doctor who will then monitor that steroid, who will then monitor the saturation, see whether you're getting better on that oral steroid tablet at home, or do you need to come into the hospital to have intravenous steroids. Now, and that is the present state of affairs. Now, when you get into a hospital admission because your saturations are dropping, that's when the role of remdesivir comes in, because it's an antiviral agent. If started, and generally less than 10 days before the onset of the illness, it shortens the duration of the viral illness and decreases the hospitalization time. It doesn't do anything to survival. And that is the reason why it's not called a life-saving drug. But it certainly, in our present circumstances, becomes an important agent in those who've got moderate illnesses who are now needing oxygen in hospital to cut the virus, to remove the virus from them and start their improvement if it was to happen earlier. And that is why we start now. That is why remdesivir is given. So there's a combination of steroids, which is anti-inflammatory, and remdesivir, which is antiviral agent, given in hospital admissions who get into the hospital for low oxygen saturation. The ones who got normal oxygen saturations are all mild, will get better themselves over a period of 10 to 40 days. And that is what, when you actually have this situation, then comes in the situations also of more recently you heard of the cocktail antibodies.
Yes.
Antibody cocktail, Regeneron, as it is known in United States, which is going to be now given approval in India and is going to be manufactured by one of the Indian pharmaceutical agents on a license from America. That agent of Roche is given in mild to moderate disease, again, not a life-saving drug, again, shortens the illness and prevents it going into the serious phase. So the only drug which actually has been shown to improve survival is actually steroids. And because it works as an anti-inflammatory. And in moderate cases, when people start dropping their oxygen, when the temperature phase goes beyond 6 to 7 days and person is still running high temperature, when the oxygen saturations are dropping, when the respiratory rate goes up, that's the time when it comes for steroids, because that's inflammation. That's no more the virus affecting you, that's the inflammation affecting you, and that inflammation has to be controlled by steroids, and steroids are life-saving in hospital settings. And finally, you asked about tocilizumab, as it is known. It's a potent suppression of cytokine. What happens is around the 9th to the 12th day, and more recently, we would say around the 7th to the 12th day, the body's immune reaction gets so strong against this virus that it's not just trying to kill the virus, but it's also trying to kill your own cells at the same time, losing the ability to recognize your own body from the virus because you created such a strong reaction to them. That starts failing your kidneys, that starts failing your lungs, that's creating a huge inflammatory surge in the body. And to suppress that is the drug called tocilizumab. It suppresses the cytokine storm. It actually suppresses the immune system completely. And when it suppresses the immune system completely, it takes you out of the cytokine storm. But of course, at the expense of the fact that you get more prone to infections, you get more prone to those situations. So it's brought in at the time when steroids are failing, when we're still seeing person getting worse, we're seeing the inflammatory markers go sky high in the failure of steroids. And we say, finally, we got to come to this drug to suppress this immune response of the body, because the immune response is actually damaging the body rather than helping it.
Something like an autoimmune.
So something like an autoimmune reaction, but we call it a cytokine storm, which is being built up inside, and we suppress the cytokine storm by tocilizumab. And that has been shown to improve mortality in some people who get into that cytokine storm at the expense of predisposing them to infections.
So naturally.
But I think the final answer to all this is that the treatment continues to evolve. The treatment to save lives at the moment is through one drug only, and that is, as I said, steroids, which is unequivocal. And for others like remdesivir, perhaps if you deep dive into the data, you may find some evidence that it may decrease mortality. For tocilizumab, it again the same thing. For convalescent plasma, we've listed that may be of benefit to some individuals, but again on larger studies, that on randomized studies, again the benefit has not been shown. Therefore, so there are some drugs of possible benefits, but no effect on mortality. And then that's where we stand at the moment. Treatment is going to continue to evolve. Where are we going to stand? And if I've got, how many minutes do I have to comment?
No, please take time, doctor.
I have to state that I was asked very recently on an interview as, so do we have a cure or will we have a cure for this? And I'm sure it was a question that you would like to ask me. That where do we stand after all this?
DRDO also coming with yes. a bill of emergency authorization.
That's right.
I think it is called 2-DG or
2-DG. You're so right. It's called 2-DG. It's a glucose molecule. It again, it is something which has been shown to decrease the length of the illness, perhaps decrease the ability to oxygen. And I trust the DRDO for actually having thought this through and actually having done a randomized trial and having brought it to every therapy which goes into randomized trials and comes out with good results may matter to an individual, especially something like this, which is cheap and which is easily available, could matter to an individual. The data is not with us at the moment, but I'm very hopeful that all these things will help in process of time. But do we have a cure? I think what we got to understand is that a virus, very difficult to have a cure on a virus. We'll have control of it, but never a cure. For multiple reasons, we haven't got a cure of hepatitis A virus. We can only have control of it. We can actually define how to protect, prevent, but no, it's going to be always there. And that goes for every virus, whether you think of AIDS, and you can name every virus that we have and get vaccinated for. In fact, the influenza virus, we got to get a vaccine every year because it just keeps coming back in different forms because there are variants. They are going to mutate. It has survival issues. It knows how to survive. It knows how to stay ahead from us. What we've got to do is control it. And if we control it well, we're going to have, by the way, we're going to have better vaccines coming out. Remember, this is the first generation of fast-tracked vaccines. We're just thankful that some of these vaccines are 90 to 95% effective. But they also, as you know, have disadvantages of -80-degree storage, disadvantages of transportation. Can we get that better? Can we get vaccines which are 90, 95% or 98% effective, but can be given to everybody, can come at a low cost, would not have this, can be stored at room temperature? All those are the future advancements which every company is working on now. And there is going to be second generation of highly effective vaccines, which can be stored at room temperature or just in a fridge. Those are going to be coming. By the way, Pfizer is already working on making sure it's not going to be -80. It's going to be maybe even -10 to 20 degrees. And then the next generation of Pfizer vaccine could actually be at 2 to 8 degrees. And the same goes for Moderna. So the second generation vaccines of all these are going to be coming. That's the first step.
This is something that we have to take every year.
Every year. And because we're going to take it every year, we're going to have easier, better, and more effective vaccines.
Absolutely.
From the same manufacturers. That's the norm. The second aspect is that we're going to have easy tweaking against the mutants also. Just like we have influenza vaccine every year, which is tweaked against the mutants of that year, that's going to happen to our vaccines as well. There's going to be more genomic studies happening and more tweaking of the vaccines. That is going to put the virus behind, backdoor. Finally, even on the treatment front of a COVID infection, of serious COVID, we're going to have better drugs, more specific agents, which are going to improve survival and decrease the seriousness of the situation in times to come. So we're going to get this virus under control. Medical science is moving rapidly ahead. This virus is going to go under control if we vaccinate, if we actually follow the COVID appropriate behavior, and we vaccinate and accept vaccination. Virus will go behind. Virus will go underground. It will only prop up its ugly head on occasions, in remote instances and somewhere or the other. But we would be easily able to suppress it again. It's going to stay with us. And that is why we'll have to be cautious for a long period of time. But we would be able to control it, provided all of us get together and understand what is our responsibility, what is your responsibility, and what's everybody else's responsibility. It's a fight together against this virus. We have to be together on it. If we got a single enemy, the whole world has a single enemy. Luckily, at this time in the world, and luckily the world, and I wouldn't say the world, luckily the humankind
is together
in against a single enemy. At least that is one good aspect which has come out of humankind realizing that it is fragile, that it is vulnerable, that we have to live in the world and not on this earth. We've got to live with each other. And if we got to live with each other, we start living in this world. Earlier on, we were living on this earth with everybody against each other in the various regions and having various differences. So let's hope we're together in this fight against this virus, and let's hope that humankind can live together happily for a long period of time, because it's got one enemy now.
Absolutely. Now, on this positive note, thank you so much, Dr. Seth, for sparing your precious time on discussing various issues relating around COVID, as well as the second wave of COVID. Thank you so much for joining the Visionary Talk series with Governance Now. And thank you so much, ladies and gentlemen, for also joining us. Thank you, Doctor. It's been a real honor. Thank you.
Thank you. Pleasure being with you. Pleasure being with you. Enjoyed this discussion. Enjoyed the interview.